in terms of typical uses, I think the microwave adds a lot, and we can talk about the technology and the delivery of the heat energy, because there's some differences in that in terms of the retroperitoneal tumors and things that we have taken on, we have been very appreciative of the rapid nature of how the microwave works, because we use that as an adjunct to decrease or basically eliminate bleeding in tumors that would have otherwise been unresectable in the past. And we started out, of course, in the early 2000s and late 90s using the arrays that we had, but the way that they deliver the energy basically through friction through the tissues takes a long time and can cause other untoward events. But in particular, with patients that have hepatitis, they have cirrhosis, after 20 years they're going to be really prone to develop liver cancers. And in fact, if they develop an elevated alpha-fetoprotein level and have a lesion that's characteristic on imaging for that, then they would be a candidate for treatment. When you take the patient to the operating room, we don't want to make a big incision like we would have done in the early 90s, so they don't heal well, they have bleeding problems, they can't go on to alternate therapies. And then in the safety net hospital system, and they're not real good at following up, they don't have a house to live in. Some of these people live in halfway houses and things like that, so we don't want them to have to manage a big wound. So we've been very interested in doing this laparoscopically. And in that event, when we had the array prior, we didn't like to open the array if we weren't sure that it was cancer. So you'd have a patient that would have an elevated alpha-fetoprotein level, they'd have a characteristic lesion, but don't have a tissue diagnosis going into the operating room. And sometimes it's difficult to get one, even though everything points to that, and most people would agree that it's okay to treat that lesion. I just have felt concerned about opening an array. And we jokingly, when I was a fellow at MD Anderson, called it Tine Show, because you stick it in and you push it open and these probes come out and you don't know exactly where they're going. So you'd have to feel around and try not to stick yourself to make sure that they haven't gone into the diaphragm or the pericardium. But we don't have the opportunity to do that that easily laparoscopically. So we can see the lesion with an ultrasound probe, we can stick it, but it's hard to see exactly where the end of the tine's going. With the microwave, we don't have to worry about that. We can pull the liver down and we know that the energy is all going directly into the tumor. So I think that's been a big advance for our patient population, and we have been interested in doing more work with that, kind of comparing our laparoscopic results to the percutaneous results the interventional radiologists do. The fact is, however, that for high lesions that are up against the diaphragm, they don't really feel comfortable percutaneously sticking those. And so we've been doing combination procedures with the interventional radiologist and myself in the operating room to get the best of both worlds. We get the radiology capabilities from the radiologist and then the surgical advantages of being able to mobilize the liver some, but not as much as we would do with an open procedure.